think of your eye as a sink. You have a faucet and you have a drain, okay? We can use medications that turn the faucet down. We also have medications that can open the drain up. And so we frequently will do both. The most successful treatment that we have is something that is called a prostaglandin analog, and that helps open the drain up so the fluid escapes more readily into the venous system and the pressure goes down. So this trabeculum is also called the trabecular meshwork, where the fluid drains through this. It's kind of like a sponge with little pores where the fluid escapes. We use something called a cold laser, which is termed a selective laser trabeculoplasty. And by selective, it means it treats just the tissue that we want it to treat and doesn't cause any secondary scarring. What we're trying to do is clean up the pores of the trabecular meshwork so the fluid drains more efficiently. The laser is used in ophthalmology in numerous different regards and in medicine in general, but it's not a cure-all. It doesn't get you off all the drops and cure you from glaucoma, but it is something that is an adjunct to the medical treatment. Now, frequently patients will go beyond medication and beyond laser and their pressure is still not controlled. So if you're on maximum tolerated medicines, that might be 2 or 3 medicines, and have had laser, and you're still getting worse with elevated pressures and the visual field is progressing and the optic nerve showing more damage, we frequently will discuss our surgical options in the operating room. Some of these procedures are done at the same time as cataract surgery, and it can be very convenient. The same incision can be used. Recovery time is very similar to a straightforward cataract surgery. Those patients generally will show a drop in their eye pressure, not as significant of a drop as some people might need. So if we don't feel like that's going to get the patient's pressure low enough, we'll move on to what we call a filtering procedure, where we're actually making a separate drain. What we're saying is we can't rehabilitate your native drain. The pressure won't go low enough. We're going to have to make a separate drain. And we do that kind of underneath the upper lid along the junction of the cornea and the sclera, which is kind of the clear part and the white part, right about the 12 o'clock. And what we'll do is after the eye is nice and numb and everything's cleaned up, we will kind of tunnel our way into the eye, creating a passageway for the fluid to go from inside the eye to outside. Sometimes we'll actually place a little tube. It's a little plastic or silicone tube that we place kind of between the eye muscles of the eye, and we run a little tube into the eye where the fluid is brought back to the reservoir, and that's where the fluid is dispersed